Thanks for joining us today. My name is Jen Henderson, and I'm the Senior Marketing Coordinator here at NueMD. Joining us for today's presentation is MACRA expert Jenny Mahaney. She's the VP of Products and Marketing at SmartLink Mobile. She is an expert on MACRA and is responsible for the product strategy of SmartLink's MACRA suite. We also have Autumn Bell. She's a Senior Project Manager here at NueMD. And we have our resident HIPAA expert, Jason Karn. He's a technology expert and the Chief Compliance Officer at Total HIPAA. We'll also try and leave some time at the end to take a few questions. So with that, I'll go ahead and hand it off to Jenny.
I think it's important to start there just because there's so much talk about repealing or fixing Obamacare, and one of the first questions I often get when I'm talking to people is, what about MACRA? Is it really here to stay? So MACRA is here to stay, and the reason for that is because the shift to value-based care is being driven by economic forces more so than political ones. I think Governor Leavitt articulated this very well recently when he said that, and I quote, "There is not a place on the economic leaderboard for a country that spends 20 to 25% of GDP on health care." The overall health care expenditure in the U.S. this year is going to be around $3.5 trillion, and that's continuing to increase every year at an unsustainable rate. About half of that is paid for by our tax dollars. MACRA was passed with overwhelming bipartisan support. If memory serves, I think the Senate, for example, I think the vote was 92-8. So definitely overwhelming support. And keep in mind that it also replaces the SGR formula. So MACRA is definitely here to stay. It's not going to go away. Let's talk about MACRA and what exactly it is. So the Medicare Access and CHIP Reauthorization Act of 2015, MACRA, it's also referred to as the Quality Payment Program, completely reforms Medicare Part B payments for more than 600,000 clinicians across the country. It repeals the SGR formula. It streamlines multiple quality programs, including the Physician Quality Reporting System, the Value-Based Modifier, and Meaningful Use. It links the majority of fee-for-service payments to value and quality via 2 different payment tracks, and we'll talk about each of those in a second. And then lastly, it provides bonus payments for participating in one of those tracks, the Advanced Alternative Payment Models. So there, as I mentioned, there are 2 tracks to choose from under MACRA. And the first one is the Advanced Alternative Payment Models. These are APMs that accept both risk and reward for providing coordinated, high quality, and efficient care. So they're already taking on downward risk. MACRA does not change how any APM functions or rewards value. It simply creates extra incentives for participation. They receive a 5% bonus. To be considered a qualifying professional, a QP, under an advanced APM, you have to receive 25% of your Part B payments through the advanced APM or see 20% of your Medicare patients through an advanced APM. Currently there are 5 APMs that qualify as advanced APM, and those are the comprehensive ESRD model, the large dialysis organization arrangement only, the CPC Plus, Medicare Shared Savings Program, Track 2 and 3 only, Next Gen ACO, and the Oncology Care Model, 2-sided risk arrangement. So note that Medicare Track 1 does not qualify as an advanced APM. So the expectation is roughly 5 to 15% of eligible clinicians are going to fall under this payment track. The second payment track is the Merit-Based Incentive Payment System, or MIPS. Medicare Part B clinicians, of course, who are not a QP in an advanced APM, will fall under MIPS. Those that bill more than $30,000 a year or provide care for more than 100 Medicare patients will participate in MIPS. The expectation under MIPS is that about 85 to 95% of eligible clinicians will fall under MIPS, and that includes physicians, PAs, nurse practitioners, clinical nurse specialists, CRN anesthetists, and groups that include such clinicians. So since the bulk of providers will be subject to MIPS, let's take a deeper dive into MIPS specifically. So MIPS scores eligible clinicians on a scale of 0 to 100, and that score is based on 4 different categories. Those categories are quality, which makes up 60% of the score in year 1 and decreases to 30% over the first 3 years. Cost, which starts at 0% in year 1 and increases to 30% by year 3. Advancing care information, which is previously meaningful use, is 25% of the score, and clinical practice improvement activities are 15% of the score. 2017 is the performance year for MIPS payments beginning in 2019. And it's also considered a transition year, so you can pick your pace of participation this year, and we'll talk about that more on the next slide. MIPS has to be budget neutral. That means that very few people will experience a 0 adjustment. The negative adjustments will pay for the positive adjustments. And lastly, the scores will be, providers will be ranked against each other nationally, and payment will be based on performance versus peers nationally. And that performance will be publicly available. So as I mentioned, there are several options for participation in 2017. During this first year, which CMS refers to as a transition year, you can pick your pace of participation in order to build capabilities and gain experience with the program. So eligible clinicians have 3 flexible options to submit data under MIPS. The first is to just submit something. You can choose to report just 1 measure in quality, 1 activity in the clinical practice improvement category, or report the 5 required measures in advancing care information in order to avoid a negative payment adjustment. Alternatively, providers that choose to not report even 1 measure or activity will receive the full negative adjustment, which is 4% in the first year. The second option is to submit a partial year. Eligible clinicians can choose to report to MIPS for a period of time less than the full performance year, but it has to be at least 90 days. And you can report more than 1 quality measure, more than 1 improvement activity, or more than the required measures in the advancing care information category. And if you do that, you both avoid a negative adjustment and you could potentially receive a positive adjustment. And then the third option is to submit for the full year. You would report all measures in all categories for the full year, and if you do that, you maximize your chance to get a positive adjustment, and then you're also eligible for the bonuses as well. And then the last option, of course, is to participate as a QP in an advanced APM. So the payment adjustments, in order to determine those payment adjustments, there is a performance threshold set for MIPS. If you're above the threshold, you get a positive adjustment. If you're below it, you get a negative one. It's also important to note that the bottom 25% will receive the max penalty. The adjustments for 2019, based on 2017 performance, are -4% to +4%. For 2020, it goes to 5%, then 7%, and then every year after it will be 9%. There's also some really good opportunities, though, for greater upside. So for top performers, there's the potential for an additional 3 times the base adjustment amount. That bonus is subject to budget neutrality, but then on top of that there is an additional 10% performance bonus from a separate budget, and that's for those that exceed the additional performance threshold score, which is for 2017 is 70 points in 2017. So out of that 0 to 100 performance score, if you get above 70, you have the potential to get up to an additional 10% additional bonus. So while there's been a lot of doom and gloom talk about MIPS, it's also, I think, important to note that if you're doing the right things to drive quality and value and you get ahead of the pack, there's some serious upside potential, and it continues to increase year over year. There's also, as I mentioned, there's a lot of talk about the potential downside penalties. I think the bigger impact also to keep in mind is that the scores will be publicly available. So while a 4 or 5% negative adjustment in the early years may not be a big deal depending on Medicare volume, the fact that commercial insurers and patients will be able to see and compare MIPS scores between your clinic and others in the community can have a significant impact on a clinic's inclusion in these new narrow network products that insurers are shifting towards. Can impact the ability to win new commercial contracts with commercial insurers, recruit providers, and patient retention could also become an issue. So I think, as you think about participation in the program and how quickly you start moving forward, it's really important to think about the broader potential impact. Another thing to think about is that performance threshold is going to be reset each year. So in 2017, the performance threshold is pretty low. In fact, you only have to report one thing to hit the performance threshold. But each year, it's going to continue to move up and get a little bit harder. So that's why it's really important to really be doing something this year and participating at the highest level as you possibly can, because the race is on and it's on now. Those that choose to delay are going to fall behind, and it's going to be harder to get out of negative territory in future years. But those that are moving in the right direction, 2017 can really be the year that you get a first mover advantage, and that can translate into some tremendous upside opportunity in future years. So let's talk about now some of the things you can do to prepare for MIPS. So at a high level, before we dive into each performance category, let's talk about some things you want to think about just at a high level. So first of all, evaluate which option, MIPS or an APM or an advanced APM, is most available to you and feasible to take on. If you're participating in an APM, it's an advanced APM. Controlling cost and quality is a team sport. So if you participate in an APM at all that's working together to achieve common goals, you can expect to perform much better than if you go it alone. Second, if you're going to fall under MIPS, how will you report? You have the option to report as an individual, as a group under a single tax ID number, or as a MIPS APM, such as MSSP Track 1. So again, controlling cost and quality is a team sport, but you want to be part of a good team that's working well together as a team, because the team score is going to be your individual score. So if you choose to report as a group, that group score will be your individual score. And if everyone is aligned and working together towards achieving the same goal, you'll be far better off than going it alone. Third, it's important to know your current state. MU and PQRS are the building blocks of advancing care information and quality. How are you doing in those programs? What are the gaps? Look at your QRUR, look at your reports and see how you're doing, how you've been doing historically. And then lastly, make sure you're optimizing your top line revenue, because that can help to neutralize downside risk. And there are a lot of ways to do that. There are a lot of different preventative programs you can participate in. But try to think about the ones that are going to have the added benefit of helping you improve your MIPS performance. So programs like the annual wellness visit, transitional care management, and chronic care management, those programs are all geared towards helping people keep people well and out of the hospital. So those are good programs to consider, because they're also going to help improve your MIPS score. Okay, so let's take a little bit deeper of a dive into each category of the MIPS composite score. So the first category is quality. And as I mentioned, in year one, that's 60% of the score, but it decreases as cost comes into the equation. You need to choose 6 measures, so it's less than PQRS. One of those has to be an outcomes measure, a specialty-specific measure, or a subspecialty-specific measure. In order to perform well under the quality category, choosing the right measures is critical. So again, review your quality and resource use report, understand how you're performing relative to your peers. So you're also going to want to pull some recent sample data and compare it to the deck files from CMS, so you can identify which measures you have the highest probability of doing well on compared to the rest of the country. So for example, in 2015, the national mean for measure 50, PQRS measure 53, the pharmacologic therapy for persistent asthma, was 95.48%. So if you're consistently doing fairly well at a 92%, say, that's still not a measure you want to choose because you're going to fall below the median. Another area you want to focus on is staying on top of your polychronic patients between visits. Quality measures are all about ensuring patients get the right care at the right time. And a large percentage of the measures, if you read through them and you've been doing PQRS, you know this already, they're geared towards chronic conditions and prevention. So staying on top of your polychronic patients between office visits, you can do a better job on your targeted quality measures and especially the outcomes measures. And also treat acute conditions early to avoid hospitalization. The cost, as I mentioned, is 0% of the score initially, but it increases to 10% next year and then 30%. This is the category that everyone has the least experience in, and without doubt will be the category that differentiates those that get bonuses. It's the one that takes the longest amount of time to approve in. So those that focus on this in 2017 are very likely to develop a competitive advantage in future years. So I would really encourage you to think about cost this year and not wait until next year when it's 10% of your score to start the process. The cost is based on 10 episode-based measures. They'll be calculated based on per capita cost for all attributed beneficiaries and a Medicare spending per beneficiary measure. To perform well in this category, think about who your most important referral partners are, how you can do a better job working collaboratively with them. Who are your high-value providers, those that provide high-quality care at the lowest cost? There's a high variability in cost between providers, and that increased cost is going to have a negative impact on your cost performance. So you've really got to pay attention to that. The key point is that in order to fare well, you really have to be thinking outside of the four walls of a single practice. Second, leverage referral management technology so that you can make sure patients are being referred to those high-value providers. You can coordinate care with them more effectively, and you can maintain visibility into your patient status as they navigate across the community of care. If you don't know where patients are and what's happening, you won't be able to manage the cost of their care. Staying on top of polychronic patients is also very important in the cost category. 93% of Medicare spend is on polychronic patients. So staying on top of the polychronics is equally important to cost as it is to quality. One thing you can consider is Medicare's CCM program as a good mechanism to stay on top of these patients. That will help you head off health issues before they escalate into an ER visit or a hospitalization. And again, treating those acute conditions early to help avoid hospitalizations will be important. Clinical practice improvement is, again, 15% of the score. You need to complete up to 4 improvement activities. So if your pace of participation that you choose is the partial year or a full year, it has to be for at least 90 days. And there are 2 types of measures. Some of those are 20 points, so you would need just 2. And some of those are 10 points, so you would need to complete 4. It's important to note that PCMH gets full credit in this category, and APMs will get at least partial credit as well. So what can you do in this category to perform well? First thing, certainly, if you're not a PCMH, think about moving in that direction. You can get credit, full credit, as long as you're certified as a PCMH by October 1st, because remember, you just have to report for 90 days, even if you're reporting for the full year for MIPS. This category just requires 90 days of data. If you're part of an APM, compare the activities that are required as part of your specific APM to the improvement activity measures. Those measures are in Table H. If you have a copy of the final rule, just do a search for Table H to get that list, or you can find it on the CMS website. CMS will score those activities in the same manner that they're otherwise scored for MIPS-eligible clinicians. And if you don't receive the MAC score, you can also submit additional improvement activities to get there. Choosing the right measures is also important in this category. So look at what activities you're already doing that you can get credit for. And also think about how you can double dip. Which measures will also have the biggest impact on cost? And there's some measures that qualify for a bonus in the advancing care information category. So look at those as well and choose wisely. Advancing care information, this is the category that was previously meaningful use, and this is 25% of your score. The overall score in this category, and I find this a little bit confusing, so I'm going to try to break this down and make it as simple as I can. There are two scores that make up your total score. So there's the base score and there's a performance score. So the base score includes 5 measures, and those are based on meaningful use 3. You have to report a yes or a numerator of 1 for all 5 of those base measures in order to get a score greater than 0 in this category overall. Your base score can make up to 50% of your overall score in this category. The performance score can actually account for up to 90% of your score, but again, you get a 0 in the entire category if you don't at least have a yes or a 1 for all of the 5 base measures. You can also get bonuses for reporting to registries, and as I mentioned on the last slide, for certified EHR improvement activities. I'll mention 2 other quick points that I think would be important to know. 2017 is the first year that EHRs, QCDRs, and qualified registries are able to submit what was previously the EHR incentive program objectives, which is now the advancing care information category. And it's also the first time that that data can be reported through the CMS web interface. And then secondly, under the EHR incentive program, EPs that were part of a group could attest together, but they were assessed as individuals. Now under MIPS, when you report as a group, you're going to be assessed as a group. So in this category, for 2017, you need to have at least a 2014 certified EHR. In 2018, you have to have a 2015 edition to submit for this category. So make sure you're moving in that direction toward the 2015 edition so you're ready January 1 of 2018. And then secondly, make sure you achieve a yes or a 1 in the numerator for those 5 base measures, because again, if you don't, you're going to get a 0 overall in this category. The MU thresholds don't apply. You only need a 1 in the numerator. But if you don't report that, a 1 or a 0, you get a 0 overall. So next, I'm going to hand it over to Autumn, and she's going to talk a little bit more about how to choose your measures and then implement those into your workflow.
Thank you, Jenny. What I want to do today, because one looming question still really remains, is what are some of the ways that I go about implementing this into my practice? And we're going to focus on the MIPS track. The most common question that we get at NueMD is, are you guys MACRA or MIPS compliant or certified? And the short answer is yes. But does this answer really help you? Unfortunately, it does not, and it will require some work on your end. So let's go ahead and walk through this little by little. First thing, make sure you learn as much as possible, because it's going to be your responsibility to pick the measures and figure out how you are going to attest to these different measures. And like Jenny mentioned, make sure you evaluate your practice. See where you stand now. That will help you to figure out which measures you're going to choose. And in that, you also need to know what your reporting options are going to be, individual or group, or through your EHR, through claims. And then make sure you're educating your staff. This is going to take some work incorporating this into your workflow. So your staff, you guys need to work as a group. The next slide that we have is going to be very helpful to access this information. We're going to go through a lot of this information in this, but this will help you refer back. And when this is published, these will actually be links to take you to the different areas that we'll talk about. So for the MIPS reporting requirements, again, we just need to learn, you need to decide if you want to do individual or group, and then learn about the reporting requirements for each category. So for improvement activities, for the first year, all you have to do is designate a yes or a no response for the activities listed on the clinical practice improvement activities inventory. For quality, your data submissions can either be administrative claims, your EHR, registries, or if you're reporting as a group, you have the CMS web interface. For cost, this does not require any data submission. CMS will actually calculate your score based on services delivered and the Medicare payments that were paid for these services. For advancing care information, like again Jenny said, you need to make sure you're using at least a 2014 ONC certified EHR. Next year you'll have to be using a 2015 certified edition. So next is how to determine what measures you're going to attest to. First is cost. As it says here, you're not required to select any measures, as I had mentioned. And cost is not actually going to be factored into your MIPS score for the first year, but it will increase to that 10%. And so you have to learn about these now. One of the links that I gave to you is going to give you more information on how CMS is putting together these episode groups and the triggering codes that go along with them. So when you get some time, go ahead and take the time to look over them and get familiar with them. This is a great tool that you can use. Again, a link is provided for you to filter out improvement activities to help you decide which ones you would like to do. You're going to need to complete 4 out of about 92 provided improvement activities. And you need to make sure that you really read about these the activities, because they can vary from humanitarian volunteer work. It could be care coordination initiatives. There's ways that you can expand your access to your practice for your patients, like telehealth or expanding your hours, and to proactively managing chronic and preventative care. Once you select the measures, be sure you download your CSV file and keep it for your records. For quality, again, there's a search tool provided for you, and what you guys see on this slide, I use the filters to filter down by specialty. I use the general practice, and then I filtered down that I'm going to submit via claim submission. And when I did that, I thought about my patient population, and I used an elderly population as my little test case. And over to the right, you can see that there are 6 measures that I picked that will meet the requirements, and it does have 1 outcome measure. So it's very easy to use. Just make sure you pick one that you know that you can do well in. And again, be sure you download your CSV for your records. One thing to remember with the quality as far as the reporting, if you report your measures via your EHR, you have to report on 50% of all of your patients. But if you report the measures via claims, you have to report on 50% of the Medicare Part B patients. And in 2018, the reported measures must have a minimum of 20 cases. In advancing care information, as said earlier, you need to make sure you have an ONC certified EHR. Without this, you run the risk of scoring 0 in this category. We already kind of saw an overview of the base score, and these base measures are listed here, which will require your certified EHR. The security risk analysis is something that you will have to do within your own practice. The e-prescribing, you have to have at least 1 prescription that has been queried from a drug formulary and sent electronically. And then the patient access, make sure that your patients have access to a patient portal where they can retrieve their medical information. And health information exchange is being able to send patient information between providers. This category in particular is going to be very important to know your HIPAA laws and how to protect yourself with that, and that is where Jason, our HIPAA expert, is going to come in and teach you all about that. So Jason, welcome aboard.
Okay, great. So yes, MACRA and HIPAA. These two things tie together. As we saw before, we have the advancing care information. And in order to qualify in this category, you have to have 5 key items. Now, HIPAA does require an annual security risk analysis and also requires secure electronic information. And these are items that are also pushed as part of MACRA. And the reason that we see this overlap is that HHS is concerned that actually a lot of practices weren't following through with doing these risk analysis, making sure that HIPAA was really implemented. HIPAA is much more detailed than what you're going to see in MACRA as far as security and protecting PHI. But one of the reasons they put this in was really to reinforce the importance of this. So as we talked about earlier, you're really going to be looking for a 1 or a yes on these items to make sure that you qualify. And this is going to be a full 25% of your score going forward. So these are things that you need to make sure you have in place and that you can document and show going forward. Now, we're going to talk more about this. I'm going to, this is more of a teaser for what we're going to talk about next week. Next week, we're going to talk more about what to do about HIPAA compliance, the steps that you need to take, how that's going to help you with your MACRA compliance, and those items. So I'm going to open up the floor here to more questions because I'm sure everybody has questions about more detail about MACRA and the different parts of it. And next week, just remember, we'll be talking about HIPAA and doing those security risk analysis, also privacy analysis and those sorts of things. So and I will open up the floor to questions.
Great, thanks, Jason. The first question is, we are signed up to be part of an ACO in 2017. Does that mean we will not be subject to MIPS?
I can take that one. If you are an advanced APM, you will not be subject to MIPS. All other APMs are subject to MIPS. There are a couple of APMs, such as MSSP Track 1, which are considered MIPS APMs. So for example, if you're MSSP Track 1, the quality measures that you're going for as part of your APM, that will be your quality score for MIPS. So they're not asking you to do MIPS quality measures and your APM quality measures. So the goal of a MIPS APM is to align what the APM is performance goals are with the MIPS program. So as I mentioned, there are 5 that are advanced APMs, 5 APMs that are considered advanced APMs. All others will either fall under traditional MIPS or a MIPS APM.
I'll move on to the next question. Is there a sliding scale or straight 4% bonus or penalty?
So there is a sliding scale. It is not linear because remember there is quite a bit of upside in bonus potential. So you can expect that scale is going to slide quickly. The bottom 25% will get the max penalty.
The next question, is there a minimum for providers that have to participate? I have seen where it was a minimum of 10,000 billed to Medicare or a certain number of patients.
Yes, it is, and we actually covered that. It's 30,000 in billings or more than 100 Medicare patients.
A follow-up to that question, if someone doesn't participate, and I guess if they don't qualify, then they don't get an adjustment. Is that correct?
Correct. You are not subject to MIPS. Also, if it's your first year in Medicare, you are also not subject to MIPS. If March 1 was your first, you just joined Medicare as a Part B Medicare provider on March 1, you are not subject to MIPS in 2017. You will start January 1 of 2018.
We have another question. Do you have to have an EHR to participate in MACRA?
Yes. It has to be 2014 certified.
The next question, are hospitals and hospitalists subject to MACRA and MIPS?
So all Part B payments are subject to MIPS, including inpatient. So hospitalists, just like other providers, if they're part of an advanced APM, they would fall under an advanced APM. But if not, hospitalists who are not part of an advanced APM would be subject to MIPS. Part A payments are not impacted by MACRA. It's just Part B payments.
All right. Will all levels of PCMH receive full credit for CPI?
So PCMH is recognized if it's a nationally recognized accredited PCMH Medicaid medical home model or medical home model. So, so nationally recognized, accredited by the Accreditation Association for Ambulatory Healthcare, the NCQA, the Joint Commission designation, or the Utilization Review Accreditation Commission, the URAC. Those all would count.
All right. The next question, are federally qualified health centers subject to MACRA and MIPS?
The service provided under an FQHC under the all-inclusive payment methodology are exempt from MIPS. Any Part B services that are provided would be subject to MIPS. The majority of an FQHC's billings would probably be under the all-inclusive payment.
All right. Next question. Where do we submit our data? Is it to CMS or can we do that through our EHR?
You can do that through your EHR. You can do that through the qualified registry. There are multiple mechanisms for submitting.
All right. How do I apply for the exclusion from MACRA?
You can have the Advancing Care Information Performance category reweighted to 0 due to hardship. And you have to submit an application for that no later than March 31st of 2018. But I don't think you can get an exclusion from the rest of the program, just the Advancing Care Information, unless someone else, one of the other panelists, knows differently. I'm pretty certain of that.
All right, and I think we have one more question. So the PQRS we used to do last year, do we no longer have to do that if we do not qualify for MACRA?
So if you fall under the 30,100 patients, you would not have to report under MACRA. MACRA and MIPS replace PQRS.
Awesome, Jenny. Thanks so much for those answers. So I'd just like to thank everyone for joining us again. I'd like to thank our presenters, and have a great afternoon.